I would like to introduce our next speaker, a very special person who is the recipient of the Lifespan's Bruce Selya Award for Research Excellence. This award is given to a lifespan investigator who, in the eyes of the selection committee, is very young, very talented, and has a very good future. So it's only appropriate that this year the award goes to Dr. Stephanie P. Goldstein, an assistant professor in psychiatry and human behavior at Albert. She received all her degrees, undergraduate, master's, and doctorate at Drexel University before completing her internship and fellowship in clinical psychology at Albert Medical School. Widely published in areas of metabolism and eating disorders, and is the recent recipient of her first R01 on interventions to improve dietary adherence in behavioral obesity treatment. Dr. Goldstein.
Thank you so much, everyone. It's great to see everybody here, and it's great to be here. I'm really excited to talk to you a little bit more about my work in using digital tools and, let's see what was that, digital tools and predictive analytics to optimize assessment and intervention in behavioral obesity treatment. So before I get started, I wanted to acknowledge a couple people because I always get rushed at the end of my presentation. So first and foremost, I wanted to acknowledge Drs. Thomas and Wang, who are my mentors at the Weight Control and Diabetes Research Center, and they just continue to provide me with tons of support and encouragement, and I wouldn't be here without them. And I'd also like to thank those who make the Selya Award possible, and the committee who saw potential in myself and my work. I'm truly honored. And of course, I wouldn't be here today also without my cross-disciplinary partners in computer science and engineering. It definitely takes a village to do this work, and so I'm really happy to be working with a lot of really brilliant people. And then before I get started, I'll also just acknowledge the funders of my work, the National Institutes of Health and the Obesity Society, and I do not have any disclosures or conflicts of interest. So Bharat did a really great job at introducing my background. You can see my credentials here. I do want to set the stage for what I'll be talking about today, which is that I've been working in the field of digital health for nearly the past decade in the course of my graduate studies and my postdoctoral fellowship. And I've been primarily applying these digital tools to the assessment and intervention of health behaviors in the context of lifestyle modification programs for weight management, also known as behavioral weight loss treatments. It goes by many different names nowadays. And my specific focus has been on the study of eating behaviors in the context of these treatments. So I'll talk a lot about digital tools writ large, more broadly, but I'll give you a lot of specific examples that are specific to my work in these contexts. So with that, I aim to talk about 4 overarching themes today. So first, I'd like to just, again, begin with how digital health can really bring behavioral science into the precision medicine space. I'll talk about examples of digital assessment and digital interventions in that regard, and then I'll end with a look to the future and a comment on health equity in digital health, which is something I've been increasingly interested in and acknowledge as really important for this work to move forward. So first, I'll start with a broad overview to situate how I think about digital tools and their role in precision medicine specifically. So as many of you in this room are aware, precision medicine is not a new term, right? Most medical and behavioral treatments, one of the issues that we found is that they tend to be designed for the average patient. And as we know, they take this one-size-fits-all approach, and that works for some patients, but not for others. And so precision medicine is tailoring disease prevention and treatment that takes, in a way that takes into account a lot of different factors, things like genes, environment, and lifestyles, behaviors. And a lot of folks in this room might be familiar with its use in the context of things like genetics, but it's been of increasing interest in how we can achieve some of the same benefits of precision treatment in our behavioral interventions for the prevention and treatment of chronic disease. So as you can see up here, I have in all these buckets things like predicting long-term behavior and clinical decision support, aiding in diagnostic profiles. Those are things that we're interested in the behavioral realm. But why haven't we been able to get there, or what's been difficult about getting there for us? So part of the issue is that precision medicine requires some degree of granularity. And granularity is the idea that in order to fully understand a concept or construct, we need to break it down into some of its smallest parts. And when we typically study behavioral treatments, we typically use a pre-post design of a randomized control trial. So we see how behavior changed from the beginning to the end. And that's really great, and it has led to a lot of important breakthroughs, but we don't really get a good sense of what is going on the day-to-day, moment-to-moment basis during those treatments. And that really kind of impairs the precision aspect of how we go about delivering treatments that are more tailored to those dynamic and changing factors. So when you think about granularity, you know, we have here these pre and post measures, and we can kind of break it down. Now when we talk about health behavior, we can break it down even further using digital health tools by saying, okay, now we have things like smartphones that we can repeatedly check in with people. We have things like wearable devices where we can get nearly continuous assessment. And we can think of that progression from less to more granular in that way. And I think my goal today and my excitement about the digital space is really, again, getting more and more granular and understanding more and more about human behavior using these tools. So my goal today is to tell you a little bit first about digital assessment methods and then digital intervention methods that really capitalize on this granularity and bring us more into the precision medicine space. So first, I'll talk about digital health assessments that I've been using in my research. So there's a myriad of different digital health assessments that I could talk about today, but we'd be here all day, so I'll pick a couple. So the first that I'll introduce is something that we call ecological momentary assessment, which I'll be calling EMA for short throughout the rest of the presentation. So these are surveys now typically delivered electronically. They used to be delivered by calling someone on the phone and asking them to report on their behavior. But now we typically just send them to people's smartphones, and we send them many times a day, sometimes up to 6 times a day. And what I typically describe this to participants as is that these surveys help us get snapshots of different moments throughout the day. So if you string together multiple snapshots of the course of someone's day, then we can actually get a really nice picture of how things and different experiences and events stayed the same and changed throughout the day. Because as we know, our days don't stay constant. We don't stay in the same space and in the same state all the time. And these methods we think of as typically more accurate than trait-level questionnaires. So when someone sits down in an office and says, you know, this is maybe mostly true of me, somewhat true of me, or retrospective recall. So, you know, here's what happened to me in the past week. As humans, we tend to be not as great at retrospective recall. And so importantly, you get a more accurate sense of what someone's going through, and then you also get a better sense of how behaviors vary over the course of the day. And these multiple observations allow you to actually start to connect events and experiences causally. So you can say something at one survey happened definitively before the experience of the next survey. And so I'll show you a little bit about how we've been doing this in our work. So I'll first talk about a trial where we use this approach, this EMA approach, to better understand adherence in lifestyle modification programs for weight management. So for those who are less familiar with lifestyle modification, we typically give dietary guidelines to help reduce overall energy intake and improve health. So that can take many forms. Typically it involves a calorie goal, following a certain type of diet plan like the Mediterranean diet or a low-fat diet. And we know that no one stays perfect on these diets. Lapses from the diet and small slips are common, and they're to be expected. We talk about them a lot in treatment, but we also don't understand a lot about them because they're difficult to study. They happen, you know, just a couple times over the course of someone's week, and we don't really know what tends to happen to make them more or less likely. So we wanted to understand more about what factors contributed to when individuals were lapsing from their eating plan. And the way that we did this is we analyzed data from a trial where individuals were just starting out in a 12-month lifestyle modification intervention. And they completed EMA, so they had those repeated surveys on their smartphones, and they completed that for the first 14 days of treatment. And they answered questions not only on just whether or not they lapsed, but we got really, really detailed with exactly how they lapsed. So did they lapse by eating a food that they hadn't intended to eat? Did they lapse by, you know, maybe impulsively eating or eating in an unplanned time? And then we also assessed a host of different triggers, primarily emotional in this study, but also, or like affect, but also things like were a delicious food present. And I'll really quickly share with you a snapshot of results just to give you a sense of the types of data and the research questions we can answer with EMA. So as you can see here, right, so we're talking about the specific type of lapse of eating something that someone had intended to avoid, eating an unplanned food. And they reported on this day in and day out, so we've got really good time-based data on exactly what days these lapses occurred. They also reported repeatedly every day on things like stress, boredom, irritability, sadness, loneliness, deprivation, hunger, fatigue, and whether or not delicious foods are available. And you think they might get tired of this, but it's pretty easy for them to do. So we actually get a lot of data with not too much effort from or burden from the participants. And with what we really wanted to understand is we wanted to understand the lagged effect. So we wanted to understand if boredom or stress was increasing, what was going to happen at the next time point? Did that make the likelihood of lapse more or less? Did it matter at all for people? And particularly what's special about EMA is that we were able to see this not just, in general, like if people have elevated stress, does that contribute to lapse? We were able to see if this is more than is typical for a person. So every single person in this room is unique and they would have their own degree, their own typical level of stress. And so EMA actually lets us say, okay, what's that typical level of stress? Okay, let's see if stress is elevated beyond that, what that does for lapse. And so that's what this graph is showing here. This is showing that, so just to kind of hit the highlights, this is an odds ratio of whether or not a lapse is going to occur at the next survey based on their current emotion rating. And that red line is basically just, it doesn't have an effect, it's the same odds. And you can see the stars here are what we found for significant values. So for things like deprivation and hunger, every 1 unit elevation contributed to about an 8% risk of lapsing at the next survey, which is small, but could be meaningful on a moment-to-moment level. Similarly here, irritability conferred less risk for lapses. And I'll show you another graph of what we were able to find, and I'll kind of tie these findings all together in a minute. So similarly, right, we were able to study, as I mentioned, lots of different types of lapses. And so this next type, eating at an unplanned time, we were able to see, interestingly, that there's different triggers for that type of lapse, right? So not all lapses have the same types of triggers. And this is something I'll continue to come back to time and time again as my little platform these days, that not all lapses are the same. And in this study, or in this finding, we can actually see that it's quite striking. For every unit increase in boredom, more than someone's typical, it conferred a 20% more, it was 20% more likely that someone would lapse in the coming hours. And then similarly, again, stress conferred less risk. So these results tell us two things. They're interesting in and of themselves, but they tell us two things. First, these results actually supported and validated extant theories about how high and low arousal states contribute to eating behavior, right? That these more high arousal states like stress or irritability are actually causing someone to be less likely to eat, whereas maybe some of these low arousal states like boredom are causing someone to be more likely to eat. But more importantly, again, coming back to this idea that I said I'd harp on, we're able to see that different types of behaviors have different types of triggers. Not all lapses from a diet are the same. And I'll table an in-depth conversation about intervention until I get to, the intervention portion. But hopefully you're all able to start, the wheels are turning where you're saying, wow, if we know that someone's at increased risk for lapsing when boredom is elevated, perhaps we should deliver intervention when boredom is elevated to prevent someone from lapsing. And I thought that too, but we will get to that in just a moment. But before I do, I want to discuss the next stages of this research, which is incorporating wearable devices. So wearable devices are an increasingly popular approach to assessing health and behavior. And it makes sense that they are, because they offer continuous observation or nearly continuous observation that can be primarily passive. So in that way, we're not burdening people. They're just, putting something on their wrist or, putting a cufflink on their arm, and we're getting all this data without much effort from them. these data also aren't influenced by self-report. So EMA is great, but it's still at the end of the day someone reporting on their own behavior, whereas passive sensing allows us to get this objectivity. So there's this high potential for less biased data in that regard. And so again, I'll illustrate how we're using that in our work. And again, I'll focus on understanding dietary adherence. So as our EMA studies indicated, lapses appeared to be this heterogeneous construct. They have heterogeneity. They're not always comprised of the same eating behaviors, and they even tend to have different triggers for when they come up. And we can imagine that every individual, if you were to try to follow some type of eating plan, would do so differently, and the way that you would inevitably be non-adherent to that eating plan, because no one can be perfect, would also be different. And so I really dove deep, and to understand this heterogeneity, I got so granular down to the bites. So what we ended up doing I had an NHLBI funded F32 that sought to use objectively measured eating characteristics to study lapses from a lifestyle intervention. So we had just a small sample, it was a small grant, but we had individuals undergo a 6-month lifestyle modification intervention, and they completed EMA in the same way that I've already described, to report on their eating, and including whether or not they lapsed from their eating or from their diet plan. And they wore a research-grade accelerometer called an actigraph. So for some of you in this room who are familiar with physical activity and sleep research, these are devices that are commonly used to objectively measure physical activity and sleep. But the particular model that we used was called the actigraph link, and it has a 9-axis measure of wrist motion. So this actually allows us to quantify the wrist roll motion of food being brought to the mouth without the user's input. So we're processing that wrist motion data with things like deep learning algorithms, and we can infer when someone is eating, and then we can even characterize that eating in terms of the number of bites, how long they've been eating, how quickly or slowly they've been eating. And what we did is we took that data and we matched it up with the EMA data. So what you're seeing here is a graph of someone's wrist motion. So the peaks indicate a lot of wrist motion. Maybe they're doing something or exercising or cleaning up around the house. And the valleys typically indicate eating, which is when that wrist roll motion is very kind of methodical and solid and the same over time. And we matched, an individual's reported eating episodes, either whether they were lapses or they weren't lapses, to these passively sensed eating episodes. And our main goal here was to try to conduct an analysis to see, do lapses look different when in terms of someone's eating behavior? And does that distinguish lapses from non-lapse episodes? And what we found was pretty interesting, I thought. Biased, but we found no main effects of any single characteristic on whether or not any given eating episode was a lapse. So bites alone, duration alone, rate of eating alone did not indicate, reliably. It wasn't able to say, this episode was a lapse, this episode was not a lapse. But we did find some interesting interaction effects. We found that eating was more likely to be a lapse if it was lower. So I'll run through these interactions and then I'll kind of do a summary at the end, because I know it can be, in writing this paper, it was difficult and it could be difficult even talking about it now. So we were able to find that eating was more likely to be a lapse if it was lower in bite count and slower in rate. So maybe like a smaller eating episode that was more bites per second, so someone was kind of waiting in between their bites. And conversely, an episode was more likely to be a lapse if higher bite counts and faster eating rates were the case. So maybe more speedy eating and maybe eating quite a bit more. And similarly, eating duration and eating rate had a similar interaction. So faster eating rate and longer eating duration was more indicative of a lapse, and slower eating rate and shorter duration also indicative. So again, a lot of different types of interactions here. But what this did is it gave us a signal that there were kind of two-ish distinct types of lapse maybe, that there were lapses that were more likely to be shorter, slower, small grazing episodes maybe, or someone maybe mindlessly eating, or someone at a party, talking and, grabbing food from here and there. And then there were these lapses that seemed to be larger, more rapid, longer. And that, in combination with other data, made us wonder about, okay, well, there's all these different lapse profiles and different lapse types. Maybe there's ways that we could go about systematically identifying these types of lapses. And that brought us to our newest R01, which I'm really excited to be getting off the ground shortly, that focuses on this idea of lapse phenotyping that I coined, and NIH was like, this is acceptable, so thank goodness. Thank God they liked it. So data like the two studies that I've presented today, and then more data that we've kind of amassed over the course of conducting these pilots, kind of tell us that the behavioral, psychological, psychosocial, contextual mechanisms contributing to lapses may differ across different lapse types, and that these relationships can even differ across people, right? So this is kind of becoming an increasingly complicated picture of human behavior. And we could think of this as resulting in different lapse phenotypes. So the way that we conceptualize this is laid out on the slide, where we have two different people having, the likelihood of a couple different lapse types, and the factors that are contributing or underlying those lapses not only stays the same sometimes for some people, but sometimes it differs, and sometimes it differs over time, and sometimes it doesn't. So there's a lot of these complicated factors that are contributing to that. And other data that I don't have time to present today tell us that these different types of lapses actually show different associations with things like energy intake and weight change. And this is really important, and hopefully something that has been coming through in the way that I've been talking about this today is that we don't expect people to be perfect on these weight management programs, but we do know that some of these behaviors are conferring risk for, poor weight loss. But it's unrealistic to tell people, just try not to lapse. So we want to try to find out what are the parts of non-adherence that we're actually targeting here, and how can we help individuals sort of set meaningful and appropriate expectations of themselves. But a lot of this is theory right now. So the clear next step of this grant is to differentiate lapse types and their associated mechanisms, and to figure out what their impact is on clinical course and outcomes. So to do this, we're applying a behavioral phenotyping approach, which is essentially a precision medicine tool that kind of improves upon the one-size-fits-all approach by elucidating underlying behavioral patterns that might confer risk for things like poorer weight loss. And so typical behavioral phenotyping studies do this by phenotyping people. They say, this person is a certain type of lapser, this person is a certain type of binge eater, and that ultimately confers risk for poor outcomes. We're going to actually apply this to understand specific behaviors within individuals. So we're actually not going to phenotype an individual, but we're going to phenotype lapses and then try to study how much those phenotypes vary within individuals. And we're going to accomplish this using a multimodal assessment protocol that uses the EMA and the passive sensing of eating tool that I just described. And we're also going to add things like passive sensing of physical activity, sedentary behavior, sleep. Really excited about geolocation and introducing that aspect to our work. So we've been working with the Spatial Sciences Institute at Brown to accomplish this, and we're really excited. And we're just starting recruitment now, but the goal of this future work is to identify those phenotypes and then to start to identify targeted treatments. So with that, I'll move into a little bit talking about how we can use the rich data from these digital health assessments to inform novel precision digital interventions. And there are tons of digital interventions out there, but I'll talk specifically about a just-in-time adaptive intervention, which I'll also call a JEDI moving forward. JEDIs are a type of intervention design that adapts the provision of support over time to an individual's changing context. So the goal here is to be delivering support directly in moments of need and when it might be most effective. And so as clinicians, this is a little bit counterintuitive because we're used to delivering intervention when people are in our offices and telling them to apply those skills out in the world. And the concept of a JEDI is, how about we deliver those interventions actually right there when they need them, possibly in addition to talking about them together in your office. And so again, I'll provide an example of my own work. So the next project I'll be talking about is the first R01 I received, we're calling it Project Adapt. And this is a smartphone-based app that is, the goal is to provide in-the-moment support for individuals who are in a lifestyle modification intervention, trying to stick to a diet, and the goal for them is to actually try to attempt to predict when they might lapse from that diet and then deliver an intervention before that happens to see if they can prevent it. So we essentially take the same EMA methods that I built on, that I discussed earlier in the presentation, and we use them to assess, I'm walking you through how this works now, right? So we're taking the EMA methods and we're using them to assess lapses and other types of eating as well. And this is the screenshot of what an EMA survey looks like. Especially in our app. And we also assess all different types of potential environmental, psychosocial, behavioral, emotional triggers for lapse. I believe we're assessing about 17 or 18 of them with every survey. And so individuals complete these about 6 times a day to check in. And once they do check in and when they complete a survey, their responses are run through a machine learning algorithm that we developed to predict the likelihood of someone lapsing in the next couple of hours at the next EMA survey, let's say. And I'm happy to speak more about the machine learning aspects of my work, but again, this could have been like a 3-hour talk if we let it, so happy to talk about it after, take questions about it. But just to orient you to the development process, we developed the predictive algorithm using several studies before we even got to developing this JEDI. So we conducted our own studies to know that it was even possible to use machine learning to predict lapses. And then we ended up using that to harnessing that in this JEDI. So once the machine learning model says, hey, someone's at risk for lapse based on their current responses, then they get delivered an intervention. So in the previous model, we offered brief suggestions from a really large taxonomy of behavior change tools, and we use these to help individuals stay on track and prevent a future lapse. So in this form of the app, as in most app development, things have taken a lot of iterations, which is why I'm sort of trying to orient myself to even where I am in this research. In this form, we use short videos and interactive questions. And if someone is too busy for a video, we have an even briefer, like 2-sentence description of the intervention that we want them to try to follow. And when we piloted this, we did so in an 8-week open trial. We found really promising results. So we found that lapses reduced significantly over time. So the value there is the mean change between lapses in week 1 and week 8, which again seems a little small, but considering lapses only happen on an average of 4 times a week or so, it was a pretty meaningful reduction there. We also saw that there was a 3% weight loss over time, which again is meaningful in the context of the fact that it was a mobile weight management program and also that it was only an 8-week period. And people seemed to be engaging with the app, and the algorithm was doing its job to the best that we could tell. And while the open trial indicated that the app was feasible and acceptable, we realized that we still needed to do a lot more work before we deployed it in an RCT. Importantly, with these types of interventions, there's a lot of factors to consider, right? So we didn't have great empirical data on what interventions to give to whom and to when, or basically anything else to help guide us in terms of, other than when someone is at risk, deliver an intervention, what type of rules should we follow? So for these type of research questions, we need a very special type of trial design called a micro-randomized trial. And micro-randomization involves repeatedly assigning an intervention option at each relevant decision point. So a point in time when an intervention might be efficacious. So in this case, when someone's at risk for lapsing. So just to kind of orient you to how micro-randomized trials differ from our traditional RCTs, at a traditional RCT, we'd randomize a given individual once to a condition at the beginning of their treatment. And what we'd say is that every time, in this context, let's say if someone was randomized to the self-efficacy intervention, every time they're at risk for lapse, they get a self-efficacy intervention. And we have all, many, many hundreds of people in all different study conditions that we want to test. And at the end of the study, if we were to do that, we'd get some info on whether or not that intervention impacted lapses overall, but we'd miss a lot of that granularity again. We'd miss for whom and when those types of interventions are most effective. And that missed opportunity is critical because it helps us optimize our Jedi and make it stronger and better and more precise. So instead, what we do is we randomize, those little symbols are someone being randomized, just FYI, to a different, I thought that was very cool at the end of this presentation, and now I'm realizing it's not as clear. We randomize them at every single decision point. And with that, we're able to model causal effects, truly of, this intervention at this time impacted lapses. We're able to understand time-varying effect moderation, so we're able to say not just, oh, someone's baseline demographics impacted whether or not they were responsive to this. We can say, time of day impacts this. How someone feels at that given moment impacts this. So there's a lot of things that we can learn from these very rich study designs. And in our micro-randomized trial, we're comparing 4 theory-driven interventions to generic reminders and to nothing at all. So you can randomize someone to a nothing condition. And I'm really excited about this particular nothing condition because it'll be for the first time in this research, we'll actually be able to say, does giving an intervention in certain moments help? Hopefully it was not all for nothing, but we did all these studies to try to develop this, and we've never been able to directly test this question. So it's very exciting, and I hope it turns out how it turns out. And I'll pause to say that, in working with my collaborators in methodology and computer science, they're all really excited about these designs and the potential that they have to continue to optimize precision interventions. But not only just to do that, the whole point of the design is not just to self-serve developing better Jedis, but it's to get rich sources of information that can help us create more dynamic models of behavior change. So much of what we know about behavior is based on static knowledge. We don't know so much about the day-to-day movements of individuals at any given time. And because of that, our best theories to guide our interventions are not quite as up-to-date as they need to be. So these types of designs can, in terms of knowing which interventions work for whom, can actually lead to more dynamic models of behavior change. And that's the hope in the field, is that we'll use these to develop better interventions, not just Jedis, but better interventions writ large. I'll get off my high horse about that and end about with a conversation about health equity and digital health. I do want to end this talk today by just discussing that, and also discussing that in the context of the future of this research. So, as many of you here are aware, digital innovations are really thought to be important tools for advancing health equity, but there's a little bit of a catch-22 there. Because these sophisticated tools, especially the ones that I spoke about today, require a lot of resources. They require things like internet, they require things like digital literacy, they require certain, sophistication of devices that people have. They can actually end up perpetuating, health disparities and inequities because individuals from historically underrepresented backgrounds don't typically have access to these things. And by not acknowledging these factors, we risk the innovation widening the digital divide instead of narrowing it. So I really quickly want to talk about a paper that I recently collaborated with a team of experts in health equity, community engagement, and implementation science, currently under review. And the position paper is really focusing on attempting to outline ways in which digital innovation can be driven by social determinants of health frameworks. And in doing so, we can create more of a mindful roadmap in terms of narrowing that digital divide, creating digital tools that actually advance health equity, by developing tools that are accessible, that are able to be implemented, that are acceptable among lots of different populations, not just the majority. And I'll focus on one. So in the paper, we posit 3 major initiatives, and I'll focus on one that's particularly relevant to what we talked about today in terms of a push for chronic disease treatment and prevention, really focusing on tackling the structural and social determinants of health. And something that I kind of want to own is that a lot of the work that I presented today and that I've done thus far is really focused on more of those intermediary determinants of health, those psychosocial factors, the behavioral factors. I'm a psychologist by training, so that's what I focused on. And now more and more we're seeing that we really need to widen that up. So when we think about digital assessment and predictive analytics, for example, we want to focus on things like starting exciting partnerships between researchers, community members, healthcare decision makers, policymakers, and using these partnerships to see if we can integrate digital tools in a way to make database, decisions or interventions or supports at the community or policy levels, which could ultimately inform structural change in the form of things like new public policies, new social movements, and decisions in the healthcare system. So that's hopefully where I see that work going. And then similarly, just-in-time adaptive interventions and MRTs typically tend to be very individual level focused. So how do we broaden that up? So one example is that these interventions could be more adaptive to directly target social determinants of health. So things like targeting physical activity in a way that considers a user's location, neighborhood safety, and other factors before suggesting an intervention option of just like go take a walk outside. That might not be possible for everyone at every time point. And they can also improve access to care if they're done right and if they're able to be accessed, which I'll talk about in a moment. And then I'll lastly just pause on future directions here. There's so many future directions of this work that it feels dizzying to me sometimes and exciting. But what I want to focus on is what needs to happen to help use these tools to advance health equity. So the caveat here is by saying that across the board, right, we need to focus on things like internet access, digital literacy, implementation, digital infrastructures. But specific to what I spoke about today, some of the future that I see for these different types of tools is particularly for digital health assessments, making sure we have rigorous validation studies. A lot of these tools are newer, they're exciting. We like to use them, and go gung-ho on them, but they're not always validated on every single population. And so there's lots of data emerging to show that some of the devices that we know and love, like Fitbits and things like that, work not as well for individuals who, for example, like have darker skin tones. That research is just always, I read it and I was like, oh my gosh, we need more rigorous validation studies. We also need things like, for predictive analytics, there's a huge problem with algorithm bias. Our machine learning algorithms are only as good as the data we feed into them. And so if we feed into them data that are not representative, they're not going to do as well. They're not going to predict well for everyone. So we need to have better, more representative data sets, but we also need to understand more about what these social and structural impacts are on algorithm bias and how that's actually impacting our machine learning. And lastly, I'll just say that JEDIs, myself included, a lot of developers use app-based JEDIs, and that's fantastic, but I'm running into this in my own research where some of these, the designs of the apps are so sophisticated that they don't run on everybody's smartphone. So we have participants come in who have, lower grade smartphones, and we actually have to give them newer smartphones so that they can run the device. So just owning a smartphone anymore doesn't necessarily mean that someone can benefit from your research. And so continuing to look at ways that we can kind of bring that down to and break it down to its basic parts like text messages or things like that, kind of going back to what we used to know instead of trying to advance even more and more and more. So I'll close and say I remain so excited about the potential for a lot of these directions and for advancing the field of behavioral medicine. And I just want to thank you all so much for listening to me today, and thank you.
We have time for one or two questions. I just have one question.
Thank you for a great talk. This was really, as a pediatrician, we see a lot of adolescents, as you know. Mm-hmm. And the good thing about adolescents is they love devices. And the other good thing is that at least now we support insurance with higher levels of insured kids with living in poverty, CHIP, and other support systems. So I'm wondering, a lot of times for us to get a device approved, it has to be shown with rigorous research that we can approve a device. And I'm wondering what your thoughts are about ultimately leveraging insurance for these kids
Mhm.
to support a device if you can really show it impacts health outcomes.
I mean, I think that's a huge initiative in terms of the folks who are invested in digital health and policy. That's absolutely something that we want to do. I think the biggest barrier is, to your point, that gathering that evidence base and is another issue where a lot of the funding to gather that evidence base lags so much behind the digital innovation, so the pace of technological innovation doesn't quite match our funding pace. So in addition to a lot of the policy level work that needs to happen for insurance to cover these devices, even just, as a provider, recommending them with enough evidence base is extremely difficult to do because of that. When something's finally beautifully validated, it's out of fashion or doesn't work anymore with our upgrades in technology. So a lot of work needs to be done there, but I'm very pro.
Great talk. So a lot of your research echoes of like fiction research, when you start talking, some of the things you're. I'm wondering if you just how this kind of standpoint with and what do you think is going on? Can you theorize a little bit? What do you think is going on? That is, you think of relapse or
So actually one of the first articles I published on JEDIs was in an addictions journal. So the overlap is very true, and I'm collaborating with someone in the UK on applying these methods to smoking cessation. So I'm really excited about that possibility and that overlap. In terms of what's going on, the reason why I'm really passionate about the eating behavior side of this work is that it's much more complicated because a lapse in the addiction world is pretty clear, right? It's when someone uses what they were trying to abstain from. Where in the eating realm, everybody eats all the time. And so the question is, how does adherence get defined there? So it's a little bit more complicated than in the addiction literature. And particularly with lapses, we're focusing a lot on, especially in this new study, we're trying to not only phenotype what happens before a lapse, but what happens after a lapse, which I think is going to be a really key sense of what we are going for there in terms of like, how does someone react when they have a lapse? Are they able to rebound? Does it, send them into a spiral? Do they want to give up? And we've done some work publishing on that as well to show that there's kind of this like middle of the road response where we don't want someone to not care, but we don't want someone to care so much that it discourages. So we have to learn a lot more about that, but that's kind of where I think it's heading, is I think that there's things that happen before and things that happen after that are.
Thank you very much.
Yep.
Congratulations.
Thank you.